Request Dr. Sanjay Chaudhary, and he'll be showcasing a recorded EVO.
Sir, just before Dr. Sanjay Chaudhary starts, so you are showing about the high vault. See, what we have been practicing with the patient with a vault more than 1,000, I think, then we used to rotate opposite direction, that is because always vertical white to white is more than the horizontal white to white. Normally it drops by around 200 microns post-op. Have you tried in this case?
Yes, I have tried in a couple of cases, it has worked also, but the point I wanted to leave behind was it is not just a low vault or a high vault alone, just what you measure, which should lead you on to an exchange of the lens. But in case the natural lens is absolutely clear or the anterior chamber is well formed and the angles are open, pressure is under control, these patients can even be closely followed up at 3 to 4 monthly interval, at least for initial year or two.
Thank you, sir.
Thank you, sir. All to you, Dr. Sanjay.
Okay, yes or no. So I'll just move on to this presentation. It is actually the STAR people, I think they saw this presentation somewhere live and they were very keen that it covers a lot of things which youngsters who are beginning with the ICL need to know. So it was a good idea to just take them through this recorded version to get an idea of how to go about putting an ICL.
We are doing his left eye, and the left eye has a power of 7.5 with 2.5 cylinder at an axis of 175, and the vision is 6 by 6. Now
it's not coming here.
Procedure. We have planned this procedure for an ICL, and I'll give you the reasons why. First, when we plan the power of the ICL, this process is you transpose this power. So 7.5 with 2.5 becomes 10, 7.5, 8.5, 9.5 and 10, and then add 1 to it, so it becomes 11. So the power should be approximately 11 with plus 2.5 at an axis of 85. Now come to this screen. So the power target is 11 plus 2.5 axis 85. So you made a mental calculation that this is what the power should be. You checked with a file that this is what the power is. So you're sure you're putting in the right lens at the right power. Many a times with multiple lenses, somebody could give you the wrong lens. So this is a very good practice to make a mental calculation of what is the power that should be there. So this is a simple method. Now, the axis is 85 and the lens has come at an axis of 90. So 90 has to be rotated to 85. So come to this last one. So if 90 has to be rotated to 85, that means you have to rotate it through 5 degrees clockwise. So here is the chart which tells you that the lens has to be rotated clockwise through 5 degrees. Now we come to this chart. This is a workup sheet for ICL. If you see, the cornea's thickness is 468 in the right eye, 464 in the left eye. So it's a very thin cornea. Now come here, the ACD. ACD is 3.47. Wow, excellent. Normally it's rare to find an ACD of this amount. ACD should be 3.0 or more, and the minimum cutoff should be 2.8, nothing less than 2.8. Now look at the white to white. The white to white digital is 11.9 and with pentacam is 12. So if it is 11.9 or 12, we look at this map. इसको जरा magnify करना. इस वाले को. So this is the chart by which we calculate the size of the ICL. Now I am choosing this 11.65 to 12.03. So this is where my 12 will come, or 11.9, and the size of the ICL will be 13.2 millimeters. So we have decided this is a parameter. 13.2 is the size, 11 minus with plus 2.5 at an axis of 85. Right, this is the calculation. Now we come to the patient, but before the patient, let me tell you that there are two ways to mark the axis. The manual axis and or the digital axis. More and more, as we are doing more and more torics in cataracts, my cataract toric rate is almost 70%. ICL toric rate is almost 95%. Even for half a diopter, I am doing a toric ICL. So more and more the ICLs, the torics I do, I am very comfortable with the digital method called the Varion. So here is the Varion. I am doing the left eye. I am sitting on the left. Can you show this closer up? I am sitting on the left, and the axis plan is 175. So this is the screen which is going to show me that the axis planned is 175. Now coming to the eye. Okay, now this patient, if you see, there is a ring there. This ring is of the Varion, and I am going to mark with the Varion a blood vessel which the Varion has already collected data in the Varion machine. So, capture karo.
Yeah, Dr. Sanjay, I will just request you to keep on telling about the people who don't have Varion.
Yeah.
So they should do the marking.
Perfect.
Yeah.
So the Varion has captured the data. I'll talk on both the sides. So Varion has captured the data, and if I reduce the magnification, you can see next. So this is 175.
Centering of the eye is very important.
Yeah. So now this is at an axis of 175, and I'll just mark this axis. So all through the procedure, I don't have to keep an eye on the Varion. Light में देखो जरा भैया, थोड़ा सा, हाँ. So this is where my axis is. Okay, उसको हटा दें. Now there are two ways to develop your axis. You can go the manual way. The best way, if you have to go manual, is the axis reference marks of 0-180 on the slit lamp. But that takes a little time because you have to go from one machine and then to bring the patient to the table.
Yeah, in Varion we don't need referral marking, correct?
Yeah. And the second best way is the bubble marker. So bubble marker, the patient is on the table, you mark the reference marks there only and ask the patient to lie down. And the third option is the digital, where you don't need reference marks. The Varion checks the blood vessel which is the most prominent, gives an angle to it, and from that basis it decides the angle for you on the eye.
Because referral marking is always done in the sitting position, because once the patient lies down, there is a torsional movement, so referral marking will not be 90, 180 axis will not be correctly marked.
Perfect. So we move on. So a two-port surgery, the direction should be towards the endothelium because you do not want to risk touching the lens capsule. So the direction is upwards towards the endothelium. If you touch the endothelium, it's not an issue, but in no way you should be touching.
And one thing more, once we are entering the eye, never press the lower lid, just to avoid collapsing the temple. It has filled up nicely anterior chamber with visceral lastic, so the chances of touching the lens with the blade is very low.
Which is 3.2 millimeters.
Now, like Dr. Sanjay has filled up nicely anterior chamber with visceral elastic, so the chances of touching the lens with the blade is very low.
So now, the ICL comes with a bottle like this.
Yeah, the most important part in ICL implantation is the loading part. So loading is the most important thing to be done. So either sponge.
So you get the ICL out, and if you can see the right leading haptic and the left trailing haptic, they have a hole. So that is how you come to know the right direction of the ICL, and that the ICL is not in the upside down position. So you would have options where the leading haptic can have a hole in the left eye, in the left haptic. So other companies are doing that, and there are some companies which are giving it the leading haptic in the right. So you have to know beforehand the lens you are using and where the trailing hole is and the leading hole is, right? Okay, now this is the cartridge filled with visco. I am placing the ICL here. So this is a siliconized foam. This is the ICL in position with a little bit coming out from the edge of the cartridge. And now to load, with the sponge, I am not holding it in the center, but a little in front of the center, and I turn it around like this, anti-clockwise. And when I turn it around anti-clockwise, the ICL will turn clockwise like a gear mechanism, and it will immediately fall into position. We have realized that a lot of beginners have a problem in loading the ICL. So this technique works very well, and let us see if it works equally well during this live demonstration. So hold it here, press, and it comes in, right? So this is the ideal position for the ICL. So now this is alligator forceps, because this is
a special forceps dedicated for the ICL only.
Okay, so this is the mouth of the alligator forceps. It should open up well like it is opening up now. Press it, it goes in through the nozzle, holds the ICL,
haptic of the ICL.
The haptic of the ICL, and pulls it into the nozzle. Okay?
This push should be in one go.
Yeah. And you can see that edge there in the nozzle. Okay, now you turn it around.
Very nicely done.
So now this is the injector, and that foam tip is now attached to the injector. Now I am loading this cartridge into the injector. So here, and I turn it in like this. It's clicked in position. Now we are ready to insert the ICL in the eye. Now there are two ways to insert it, under visco or under hydro. Both techniques are very good. The advantage of hydro insertion is that you are not using too much of visco, and whatever strands of visco that are there in the injector, they come out in a few seconds. Whereas if you insert the ICL under visco, then the visco may get attached to the plates of the haptic, and some of it may still stay back and cause a secondary or an early post-op rise in IOP. So an irrigator, if you see my parameters, the IOP is at 40 on the screen. So low IOP, and this ICL is in position, and
like this is important, like below the irrigation we have to implant.
Yeah, so you see it opening out, this is how it should open.
Any rotation.
It's about 2/3 in or 3/4 in, then you can let it open slowly, and the ICL is in position, right? Now you can see a central hole. You can see the axis mark. There is one axis mark here, one axis mark here. Now what I am going to do is, whatever little visco was there which came in with the injector, just in a few seconds that visco is out. I don't have to run after all of that, just little. So that's it, and I'm ready to go to the next step. So that is the advantage of inserting it under hydro. It's not about time, it's about visco, which is easily removed. Now, before I tuck the ICL into the required position, I have to bring the ICL and align the axis marks. These are the axis marks to the axis marks on the cornea. So these are aligned, and now I have to start the tucking process. So एक जरा marks दिखा दे, वो दिखा दे, very on. So now या थोड़ी देर हटा दे, let me show it without that. हटा दे. So first the distal one and press and tuck. One gone. Simple. The second one, tuck, tuck, tuck and twist, and it goes into the eye. Second gone, and it is on the axis mark which are shown on the cornea. Now you are coming to the third one. So this one first, grab, 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 get to the periphery and tuck. The third in position, and with the left hand I am ensuring that the ICL does not move out of its axis. And then the fourth one, grab, grab, grab and tuck and in position. Now see, I have tried my level best to keep the ICL on the axis. It looks on the axis, but let's confirm it with the varion. Check.
Yeah, this is one of the excellent way of putting the toric ion along the axis, because once you engage the ICL below the iris.
Okay, so the idea was to show you actually almost unedited some very basic steps so that ICL implantation is actually not very difficult. It is simple. The steps are simple. So this just gave you an idea how you could go through these steps simply. There was actually no struggle, nothing. And since it was almost a live continuous performance, you could actually see that there is no magic from behind. They are just simple steps to put an ICL in the eye. Thank you.
Thank you, Dr. Sanjay Chaudhary, for that wonderful